Hi everyone, hope you're all doing well. So, today we are starting with the first aid review series. Before beginning the session, I would like to lay upon the fact that reading first aid is not supplemental to your basic knowledge acquired through the standard books and the ward rounds. Only after you complete studying the recommended curriculum for MBBS, it is advised to read the USMLE, and it is important for the last 10 days of revision, as already stated. It is the best resource for revision and it will help you fetch those marks lost to, quote, silly mistake, which I call blunders. So, what you can do is you can grab along your first aid and annotate along with me. PS, I'm using the 2021 edition. Or you can also make your own note, but I think it's better if you mark in first aid itself, as while revising, you'll also be able to look at the important images when you read the mark points in the first aid. But a word of caution, revise and re-revise from the same source so that it forms a visual memory as well. Without further ado, let us begin with the first topic, that is respiratory system.
So we'll be starting with embryology, and the first topic is lung development. Right, so it takes place in 5 stages, which is the embryonic stage, right, where there is a formation of trachea and bronchi from the lung bud. Then pseudoglandular stage, where endodermal tubules gives rise to the terminal bronchioles, right. Then in canalicular stage, there is formation of respiratory bronchioles. In saccular stage, alveolar ducts are formed, and finally in alveolar stage, the adult alveoli are formed, right. As you can also see in this diagram, after the canalicular phase or the formation of respiratory bronchiole, that is approximately at 20 weeks, the surfactance starts to increase, right, and the maximum surfactant is present by 38 to 40 weeks, and then after birth the surfactant again decreases slightly in amount. What is the importance of knowing that the various phases is that there will be a difference in the epithelium of all these stages. For example, we will start with, suppose, pseudostratified epithelium, right, and then it will change to columnar, cuboidal, and finally squamous epithelium, which we will see in the later things. Now, what are some of the developmental anomalies? If there is a problem at the embryonic phase, it leads to the formation of a tracheoesophageal fistula, where the esophagus is atretic and there may be a connection with the trachea. That is, there can either be a proximal connection or there can be a distal connection. Most common is the tracheoesophageal fistula with a distal communication to the esophagus. Yeah, this is the most common, and this is also known as the C type of tracheoesophageal fistula. Then second congenital lung malformation is pulmonary hyperplasia, right. It is due to poorly developed bronchial tree, and it is usually associated with congenital diaphragmatic hernia, right, and bilateral renal agenesis, right. This is the Potter's sequence. All right. Third can be a bronchogenic cyst, which is caused by abnormal budding of foregut, right, and there can be dilatation of terminal or large bronchioles. And remember that this is the most common middle mediastinal mass. Now, mediastinal masses are very important. Anterior mediastinal masses, most common is thymoma, and the anterior mediastinal masses are remembered by 4 T's, right, which is thymoma, teratoma, terrible lymphoma, thyroid, right, that is substernal goiter. Now let us move to the types of cells. So the first type of cells are the club cells, right? These are very important. These are the Clara cells, and you need to know the type of epithelium because it is different from the entire respiratory tree, right? So the epithelium is non-ciliated, low columnar, right? We'll revise it again when we'll do the epithelium, but for now just remember this, right? And remember that Clara cells or club cells are located in the bronchioles, and they degrade the toxins via cytochrome 450. All right, and they also form a component of the surfactant, and they are the progenitor cells for the club cells as well as the ciliated cells, right? Then coming to the alveolar cell types, the alveoli are of two types, type 1 pneumocyte and type 2 pneumocyte. So this question was asked in 21 INI, right? And an electron microscopy of the alveoli was given, and the question was like which of the following is responsible for ARDS. It was a clinical question, and the diagnosis came out to be ARDS, and some structures were marked like this: A, B, C, D, and you had to identify which of the following is responsible for the ARDS. So ARDS is basically due to a dysfunction of type 2 pneumocytes, and how will we identify the type 2 pneumocytes is by the presence of lamellar body. Okay, this is very important. Now type 1 pneumocytes, they are present in the majority. 97% of the pneumocytes are type 1 pneumocytes, and they are responsible for the gas exchange. While type 2 pneumocytes, they serve as precursor cells, right, for both type 1 and type 2 pneumocytes. And second, they secrete surfactant, and surfactant is secreted from the lamellar bodies. Hey, that is why you should know the presence, you should know the importance of lamellar body, and that is why it was asked in the INI-CET. Now, what is the function of surfactant? Is that it decreases the alveolar surface tension, and therefore it prevents the collapse of the alveoli, right? And it increases the lung compliance by decreasing the lung recoil. Now, it is composed of lecithins, but the most common or the main lecithin that you should know is the dipalmityl phosphatidylcholine, right? The synthesis begins at 20 weeks, while the mature surfactant is formed by the age of 35 weeks. Therefore, a question is always asked that if a child has to be delivered before 34 weeks, then corticosteroids should be administered in the child. Also, one more question, remember that if delivery has to take place before 32 weeks period of gestation, then along with corticosteroids we also give magnesium sulfate. Okay, these are two questions related to gynae, just on a side note. Okay, then the next cells are alveolar macrophages, and as all the macrophages in the body, they phagocytose the foreign material and they release cytokines and proteases, right? Then a special type of macrophage called as the heart failure cells, it is located or it is found in cases of pulmonary edema and or alveolar hemorrhage, right? And what are they? They are nothing but they are just hemosiderin laden macrophages. This question was also asked in 21 INI-CET or NEET, in any of these two exams. I don't remember which one, but this was a question. An image of heart failure cells was given, and it was asked like where would you find this, or just you need to identify the heart failure cells. So that is important, right? So how will you identify hemosiderin? It is a brown pigment, and you can see brownish pigment in the alveoli, which is lung. So those are heart failure cells associated with pulmonary edema or alveolar hemorrhage. Then coming to a disorder of decreased surfactant production or surfactant deficiency, that is neonatal respiratory distress syndrome. So since there is decrease in surfactant, what will happen? There will be increase in surface tension and the alveoli would collapse, right? Now what happens is that in X-ray we see that the lungs are black. Why that happens is because of air, right? Air is black, and when air is filled in the alveoli appears black and the lung field appears black. Now in NRDS, what happens is due to collapse of alveoli, this blackness will disappear and it will give to the appearance of a ground glass appearance on the chest X-ray. Here you can see that the chest X-ray is hazy, right? And this is the ground glass appearance. Now one more thing you might confuse is that the heart appears enlarged in size, right? But since this is infant or neonatal X-ray, you need to know that the children have presence of thymus. So this is a thymic shadow which is giving a globular appearance to the heart. The heart is perfectly normal. Here there is just whitish appearance of the lungs, which is called as the ground glass appearance. Right. Now what can be the risk factors for NRDS? The most important risk factor that you should know is prematurity, right? Then then diabetes during pregnancy, C-section, right? C-section can lead to transient ground glass appearance, which is known as transient tachypnea of newborn, right? How do you differentiate NRDS from TTPN? That in TTPN, if you see, there will be bulging of fissures, right? And in NRDS there will be just plain ground glass appearance. Also TTN will resolve after 72 hours post surgery, while NRDS will not resolve on its own. So how do we prevent neonatal respiratory distress syndrome? Is by giving corticosteroids to mother before birth, right? And after the birth, therapeutic oxygen can also be given to the baby. But while giving oxygen, you need to be careful about some complications of therapeutic supplemental oxygen, which are retinopathy of prematurity, IVH, and bronchopulmonary dysplasia. Okay. You can remember then by mnemonic RIB. These are all the complications of supplemental O2 in a neonate or a preterm baby. That is ROP, IVH, and BPD. Now screening for lung maturity, it is done by the LS ratio, which is lecithin to sphingomyelin ratio in the amniotic fluid, and the normal is more than 2. If this ratio is less than 1.5, it is predictive of NRDS. Also, a persistent low oxygen tension can also be a cause of risk of patent ductus arteriosus. Now this is a graph, and all the graphs from USMLE are important because you have seen the importance of graphs, and the graphs are very easy. You should not be scared of them, just see what's written. So in the x-axis we are seeing the gestational age in weeks, okay? So 20 weeks POG, 36, 35 and so on. And on the y-axis here the concentration of various substances is given. Now you can see the first is lecithin. So with the period of gestation or the increasing period of gestation, the lecithin increases while the sphingomyelin decreases, right? And as you can see, the overall effect is that LS ratio increases with period of gestation, and a normal LS ratio is 2. So now what they can do is they can hide these things, right? And they can ask, what does this line represent, or what does this line represent? So it is easy. You know that LS ratio would increase, right? So the line that is increasing maximally would be LS ratio. Then the line that is increasing but less than the LS ratio, this would be lecithin. And the line which is decreasing would give sphingomyelin. Also be careful to see the values in the x-axis. They are very clever. Sometimes what they do is that they give in reverse, like 40 weeks, 30 weeks है ना, ऐसे. So अगर ऐसे दिया होगा, so 40 weeks से इधर जाके the line that will be decreasing would be lecithin, right? And the increasing line would be sphingomyelin. it is still decreasing only sphingomyelin, it just looks like it is increasing, okay, because the period of gestation is given in the reverse order. So basically what I was trying to tell you is that graphs are not scary, and we are scared from seeing all those graphs. All we should do is just look carefully at the axis, what is written and what they are trying to ask, right? Any question can be solved if you use a little bit of common sense in the exams, and for that what is required is a calm mind. Yeah, moving ahead. Now let us talk about the anatomy of the respiratory system, and first we'll start with the respiratory tree. It is divided into two parts, the conducting zone and the respiratory zone, right? The conducting zone is up till the terminal bronchioles, and you can see the first type of epithelium is a pseudostratified columnar epithelium, which is present in trachea and bronchi. Also note the presence of cartilage, and the smooth muscle layer is very thick. Also goblet cells can also be seen in trachea and bronchi, right? In bronchioles you see there is absence of cartilage, right, while there is presence of club cells, which we read that club cells are non-ciliated columnar epithelium, and apart from that the ciliated cells are simple ciliated columnar epithelium in the bronchioles. Then moving downwards to the terminal bronchioles, the epithelium changes to simple cuboidal epithelium. Okay, you can see that from pseudostratified, yeah, to columnar to cuboidal, the epithelium is decreasing, like as you basically it is decreasing in height, and finally the epithelium would be a simple squamous epithelium in the alveolar ducts and the alveolar sacs. Okay, why this is happening is because you can imagine that we are moving from a low pressure to a high pressure system, and as the pressure increases, yeah, it is exerting pressure on the cells, and the cells keep on assuming a flatter appearance as you go from trachea to the alveolar sacs. Okay. Respiratory bronchioles also have simple cuboidal, and there can be a transition of simple squamous epithelium, and the alveolar sacs, they have simple squamous epithelium only. Also the presence of type 1 and type 2 pneumocytes along with alveolar macrophages will make it sure that you are in the alveolar sac, right? Then coming to the lung anatomy, the right lung, it has three lobes which are divided by two fissures. First is the horizontal fissure and second is the oblique fissure, while the left lobe, it has two lobes, that is the left upper lobe and the left lower lobe. Now the left upper lobe is further divided into the upper segments and the lingular segments, right? Basically lingular segment is homologous to the right middle lobe. Okay, so basically you see on the right side the area of the lung adjoining the heart is the right middle lobe, while the area of the lung adjoining the heart on the left side is the lingular lobe. Now coming to the relation of pulmonary artery to the bronchus, right? So the mnemonic is RALS, and this was asked in 22 INI-CET. Now what is RALS? Is that right pulmonary artery is anterior and left pulmonary artery is superior to the bronchus. Now let us see in the CT. Okay, so this is a black structure. So black matlab air. So this is carina. Carina, why? Because the trachea has bifurcated into two bronchus and the point of bifurcation is called the carina. So you can see this is the right bronchus, this is the left bronchus. So if you see the pulmonary artery, right, this is anterior, take a CT mein, this is posterior. How? Because posterior you can see the presence of the vertebrae, right? Also remember in CT this is always right and this is always left. That is like true for all cross section images, right? This is right and this is left. Then anterior and posterior. How will you identify anterior posterior? By looking at the vertebra. So in the right side the pulmonary artery is anterior to the bronchus, while on the left side if you see the pulmonary artery is superior to the left bronchus. All right. So this question was asked, that they asked what at the hilum, what is the relation at right lung, I think they asked. So yeah, that was very easy. Pulmonary artery, then bronchus, and they asked anterior posterior relation only. Okay, so this should have been the answer. They also gave options like vein, artery, bronchus. Yeah, so you could have picked an option where artery was before the bronchus. But this is the mnemonic if you want to know. The VAB anterior forms the anterior posterior relation at the hilum of the right lung. Right. This is a chest X-ray which is showing the same thing, that the part of the lung adjoining the heart would be right middle lobe, and the left side would be the lingular lobe. Now, an important thing to note is that if there is a right middle pathology, it will obscure the right heart border. Similarly, a lingular pathology will obscure the left heart border, and this is known as silhouette sign. Basically, silhouette sign is a misnomer. There is loss of silhouette, if you may say, on both the right side and the left side in respective RML and lingular lobe pathologies. Next are the structures of the diaphragm, which is very important again, as it is asked in every INI-CET exam. So first let us see what are the openings in the diaphragm. Okay. So diaphragm has three openings. First is the opening of the inferior vena cava at T8, then esophagus at T10, and aorta at T12. Always remember that veins would be on the right side and arteries will be on the left side, because heart is on the left side. ठीक है, तो heart से arteries निकलती हैं like aorta, so it will be on the left side. Like that is the basic thumb rule or common sense, if you may say, right? Then in between these two, the opening would be that of esophagus. So right is vena cava, left is aorta, and beech mein esophagus. They can also give you a CT section. This will appear same only, and you can easily mark that. Now to know what are the structures, the mnemonic is I8, 10X at 12. So I is IVC opening at T8, then at T10 it is the esophagus opening, right? And the structures that pass are the esophagus and the vagus nerve or the 10th nerve, right? Also remember that with the IVC opening, the right phrenic nerve also passes through it. Here both right and left vagus nerve passes through the esophageal opening. Then 12 is T12, and it is an esophageal opening for passage of aorta, esophagus and hemiesophagus and the thoracic duct. Okay. This also will help you to remember that thoracic duct is a left-sided structure and is present on the left side. Now, the diaphragm is innervated by the phrenic nerve, right? Phrenic nerve, right phrenic nerve was passing through the T8 opening. Now, this is a diagram which they ask all the time in NEET. Okay, let us just look at it. So, this muscle is the scalenus anterior, this one, right? Now, you can see a structure passing in front of it, right? This is the phrenic nerve, right? Then medial to phrenic nerve, let me rub it, this structure is vagus nerve. You can see it is coiling around the left subclavian, it is coiling around the right subclavian artery, right? And then the vagus nerve continues as the recurrent laryngeal nerve. Okay, so basically you can see three nerves, medial to lateral. They are recurrent laryngeal nerve, vagus nerve and phrenic nerve. How would you identify? First, identify the muscle. Yeah, first identify the muscle, this one, that is the scalenus anterior muscle. The lateral most would be phrenic nerve. Medial to it would be vagus nerve, and then medial most would be the recurrent laryngeal nerve. Okay. Here you can see this is the subclavian artery on the right side, on the left side, and it is giving rise to vertebral artery. Okay. Arteries are muscular structures, so they will be pipe-like, while nerves are cord-like structures, like they are flattened a bit. Okay. So this is a way to differentiate between artery and nerves. Cadaveric images are important, and we'll be doing more of them, or we'll be looking at cadaveric images separately, not with this USMLE review. I just thought to mention it here because diaphragm and phrenic nerve are very important. Okay, now let us move ahead and do the physiology of the respiratory system. So the first topic in physiology would be the spirometry. Now again, in spirometry you don't need to remember all the values. What they do is that they basically give you a curve and they ask what would be the inspiratory capacity, for example, right? So let us look how we will solve the question by just looking at the graph. So in the graph you can see on the y-axis the values have been given, which are the volumes, and the first is the tidal volume, which is the air that moves into the lung with quiet inspiration, right? And this is 500 ml. Now if you see from the graph, 2.7 minus 2.2, which is 0.5 ml, right? That is 500 ml. Now inspiratory reserve volume is the air that can be breathed in after a normal inspiration, right? And it is 6 minus 2.7. 6 minus 2.7, that is approximately 3.3 liters. See how easy it is to remember that. The next is the expiratory reserve volume. That is the air that can be breathed out after a normal expiration, and the value is approximately, you can subtract these two, which is approximately 1 liter, right? These are the things that you should know. Now the capacities are a combination of two values. For example, inspiratory capacity, it is actually the air that can be breathed in after forceful expiration, and it is basically the sum of tidal volume and the IRV, right? Similarly, expiratory reserve volume would be the sum of tidal volume and ERV. And functional residual capacity, it is basically the volume of gas in the lungs after normal respiration, given by expiratory reserve volume plus reserve volume. ठीक है, so जितने भी reserve volume है, if you add them, you will get functional residual capacity, right? And vital capacity is the maximum volume of gas that can be expired after a maximal inspiration, and it is given by the addition of IRV, TV and ERV, पूरे तीनों के तीनों, and then TLC is the total lung capacity if you include all the lung volumes. One thing I didn't tell you was residual volume. It is the air that is left in the lung after maximal expiration, right? While ERV is the air left in the lung after normal expiration. So these are all the values you need to know. Next thing is the dead space. So basically we have physiological dead space, right? Anatomical dead space and alveolar dead space. Anatomical dead space is the dead space which is present in the conducting airways, that is the airways that are not taking part in the exchange, while alveolar dead space is the inspired air that is not participating in the exchange. The lung is not diseased, or in normal individuals, right, this is 0. So basically the physiological dead space would be equal to the anatomical dead space. But if there is some diseased lung or there is ventilation perfusion mismatch, then the physiological dead space is more than the anatomical dead space. The formula for the physiological dead space, right, it is represented by VD, D for dead space, and it is given by the multiplication of tidal volume with PaO2 or the PaCO2, that is the arterial CO2, minus PeCO2, that is the partial pressure of expired CO2, divided by PaCO2. Next is minute ventilation, which is given by the formula tidal volume into respiratory rate, and suppose the respiratory rate is 12 breath per minute, minute ventilation comes out to be approximately 500 into 12, which is 6 liters per minute, right? Next is alveolar ventilation, right? It takes into account the dead space which is not participating in the gas exchange, and is calculated by tidal volume minus Vd, that is the dead space, multiplied by the respiratory rate. Tidal volume is 500 ml and the dead space is approximately 150 ml. If you calculate from this equation and multiply by 12, this will be 350 into 12, which is approximately 4.2 liters per minute. So you can see the alveolar ventilation is definitely less than the minute ventilation, right? Now let us look at the lung and the chest wall. So what happens is that the lungs, they have a tendency to collapse, right? And the chest wall, they have a tendency to go outwards. So basically the chest wall is exerting a pressure outwards and the lung is exerting a pressure inwards, right? FRC, that is the functional residual capacity, that is the volume at which the airway and the alveolar pressures are equal, right? And the intrapleural pressure is negative. So this is the FRC. Here the airway and the alveolar pressure is equal. This is equal to this, and the intrapleural pressure is negative. That at FRC equilibrium exists, that is the inward pull of the lungs will be equal and will be equal to the outward pull of the chest wall, and there will be no collapse of the lung. Also the pulmonary vascular resistance will be minimum at FRC. Okay, let us look at these curves. So this is variation of lung volume, alveolar and intrapleural pressure with inspiration and expiration. Okay, so during inspiration definitely the lung volume will increase, and during the expiration the lung volume will decrease. During the inspiration the alveolar pressure is negative, while during expiration the alveolar pressure is positive. Then the intrapleural pressure becomes more negative during inspiration, while it is less negative during the expiration, right? These are very important curves and they can be asked as it is. Next is the compliance. What is compliance? It is nothing but a change in lung volume for a change in pressure. Now if you remember, we used to read in physics that y is equal to mx plus c, right, where c was a constant. Let's remove that, and m used to be the slope, right, dy by dt. Similarly, compliance is nothing but a slope of the volume and pressure curve. Okay, this is the y-axis, this is the x-axis. Suppose, let us take this curve. This is a normal curve. The slope which is given by delta v by delta p. It is inversely proportional to the wall thickness, and it increases with surfactant. Definitely, we read that surfactant was responsible for increasing the compliance of the lung, right? And more the thickness, more the wall stiffness, more the wall stiffness, lesser will be the compliance. Okay, now let us look at the factors causing an increase and the decrease in compliance, right? The first factor that is causing an increase in compliance is emphysema, because in emphysema it is easier to fill the lungs. Why? Because of loss of elastic recoil of the alveoli. Since there is no elastic recoil, lungs are easier to fill. Imagine a balloon which has already been inflated, right? It is easier to fill that balloon. Similarly, emphysema is just like an already inflated balloon, which is easier to inflate the second time we inflate it. Next, the condition that decreases the compliance is fibrosis. Just imagine fibrosis to be a hard lead pipe. It is very difficult to inflate a metal, so you won't be able to inflate it properly. Okay, fibrosis is also the same thing. It is very hard to fill the lungs, right? And the other causes can also be pneumonia, ARDS, where there is something already present in the alveoli. Okay, when something is already present in the alveoli, it would be very difficult to inflate it with air. That is, the air entry decreases and the compliance also decreases. Now if you look at these graphs, how will you determine whether compliance is increasing or decreasing, as again it is given by the slope. By visually seeing, you can see that this green line of emphysema, it looks steeper compared to this yellow line of fibrosis. Increase in slope means increase in compliance. Next is the hysteresis loop. So what is hysteresis? It is that the lung inflation follows a different pressure volume curve than lung deflation. Why? Because during inspiration, you need to overcome the surface tension as well, right? So the compliance will be lesser during inspiration, while during expiration the compliance would be more. So the difference in the compliance during expiration and inspiration, this is the hysteresis loop. Now the next thing we need to know is a little bit about hemoglobin. So hemoglobin, the normal adult hemoglobin HbA, it consists of 4 chains, alpha, 2 beta, and it has 4 heme proteins in between, and it binds to oxygen. So one hemoglobin will bind to 4 oxygen. Also the binding is called as positive cooperativity, that is when one oxygen binds, it increases the affinity for the next oxygen, right? Also the protein of the hemoglobin acts as a buffer for the H plus ions. Myoglobin, it consists of single polypeptide chain, right? Like hemoglobin has 4 polypeptide chains, myoglobin has just 1 polypeptide chain, and it has higher affinity for oxygen than hemoglobin. Now comes a very important topic, which is the oxygen content, right? So the oxygen content, it is given by 1.34 multiplied by hemoglobin multiplied by the saturation. Why is that so? Because normally 1 gram of hemoglobin, it binds with 1.34 ml of O2, right? So for 15 gram hemoglobin, which is normal, what we will do, we will multiply 1.34 into 15. Therefore 1.34 into hemoglobin into oxygen saturation, plus 0.003, which is the solubility of O2 multiplied by PaO2. So this will be basically dissolved O2, right? Now remember that the oxygen content, it is determined by 3 factors: hemoglobin, saturation, and PaO2 or the dissolved O2. If any of these 3 decreases, the oxygen concentration will decrease, right? Now let us take an example which is very easy, that is anemia. Now in anemia, what happens is that there is a decrease in hemoglobin, but the SpO2 and PaO2, they both will be normal because they are not related to the hemoglobin content, right? Only hemoglobin is decreased, SpO2 and PaO2 would be normal, but the oxygen content will decrease. Why? Because hemoglobin decreases, so oxygen content is bound to decrease. In polycythemia, the reverse takes place. Increase in hemoglobin would lead to increase in oxygen content, while SpO2 and PaO2 would be normal. Cyanide poisoning, everything is normal. There is normal hemoglobin saturation, PaO2. Then what happens is that basically there is a block in the ETC complex 4. In carbon monoxide poisoning, there is increased affinity of hemoglobin for carbon monoxide, right, which is 200 times more than oxygen. So this leads to binding of hemoglobin with the carbon monoxide, right? Hemoglobin content is normal, but there is decreased in saturation due to the competition between CO and O2, right? Again, the dissolved O2 will be normal, but the total oxygen content will decrease. In methemoglobinemia, what happens is that again hemoglobin is normal, but the saturation decreased because of the presence of iron, ferric iron, which has poor binding for O2. Again, this would be normal, but the oxygen content will decrease. So we can see that in anemia, the major culprit for hypoxia is decrease in hemoglobin, causing the decrease in oxygen content. In methemoglobin, it is the decrease in saturation due to the presence of ferric iron. In carbon monoxide poisoning, it is due to increased affinity for carbon monoxide, which causes a decrease in the SpO2. Now talking about methemoglobinemia, oxidized form of iron is present, which is the ferric iron. Now oxygen binds to the ferrous iron. The ferric iron, it has increased affinity for cyanide. This leads to tissue hypoxia due to decreased O2 saturation, causing a decrease in the O2 content. Now, a methemoglobinemia may present with cyanosis or with chocolate colored blood. Right? Some of the causes of methemoglobinemia are dapsone. This is very important. Whenever you see a drug related to anything, just remember that this is very important. Okay? Then some local anesthetics like benzocaine, again an important question, and nitrites, which can be for dietary intake or polluted or high altitude water resources, right? And their basic pathology is what? They convert or they oxidize the ferrous to ferric ion. Okay. What is the management? You can treat it with vitamin C and methylene blue. Now let's talk about carbon monoxide and cyanide poisoning. Right, cyanide poisoning, it is also called as histotoxic anemia, and carbon monoxide poisoning is known as anemic anemia. Right, the cyanide poisoning, it is due to the exposure of synthetic products of combustion, right? Then amygdalin ingestion, which is found in the apricot seeds, and cyanide ingestion or in fire victims as well. It usually presents with headache, dyspnea, drowsiness, right? And the patients have a cherry red skin, not cherry red spot, or a cherry red discoloration, you may say. And also the breath is bitter almond odor. Right, now we have already seen that the lab investigations are normal. The only thing that is increased is the LDH, that leads to metabolic acidosis. Oxygen dissociation curve will also be normal. How do you treat it? We treat cyanide poisoning by decontamination followed by administration of hydroxycobalamin, because it binds with cyanide, right, forming cyanocobalamin that has a renal excretion. Then nitrites can be given, which oxidize the hemoglobin to methemoglobin, right? Nitrite was a cause of methemoglobinemia. Okay, why? Because it was oxidizing the iron. Again, here it will oxidize the ferrous to ferric, leading to the formation of methemoglobin, and methemoglobin binds with cyanide, which we already studied, and this would lead to decrease in toxicity of the cyanide. Another thing we can do is administer sodium thiosulfate. Right, what happens is that it increases the cyanide conversion to thiocyanate, which can be excreted by the kidneys. Now carbon monoxide poisoning, it is usually caused due to motor exhaust, gas heaters, right, in fire victims. When we sleep in a room, a poor ventilated room with say we should not do it. Why? Because it leads to the formation of carbon monoxide. The symptoms are again same, like a headache, vomiting, confusion. The patients may also have cherry red discoloration with bullous skin lesions, but the important thing is that multiple victims may be involved. For example, the family members due to faulty furnace. Looking at the lab investigations, we've already done PaO2, that is a dissolved O2, is normal. There is increased carboxy hemoglobin. There is decreased saturation causing a decrease in O2 content. And if you look at MRI, you will see a characteristic appearance where there is bilateral globus pallidus hyperintensities. Now, how do you identify it? See, this is the ventricle, lateral ventricle. This is the caudate. This is the thalamus. And here we can see putamen and the globus pallidus. So this hyperintensity in the globus pallidus, which is bilateral, right? Bilateral globus pallidus, increased signal intensity. It is characteristic of cyanide poisoning. Also, it causes a left shift of oxygen dissociation curve. We'll just do the oxygen dissociation curve in the next topic, right? And you already know that it decreases the oxygen saturation by competitively binding to hemoglobin with a 200 times greater affinity than oxygen. How do we manage it? The treatment is administering 100% O2. In severe cases, even hyperbaric chambers can also be used. Right. Now, looking at the oxidation dissociation curve. So here on the x-axis you see PO2 and the y-axis is the hemoglobin saturation or the percent of HB saturation. You can see the curve is sigmoid. The normal curve is sigmoid in shape due to cooperative binding, and it follows a saturation kinetics, right, which is very obvious. Now comparing it with the myoglobin would have leftward shift because it shows saturation kinetics, right? It has increased affinity for O2 binding as we already studied, and it will be towards the left. Now basically what happens is that all the condition that causes oxygen unloading or they deliver oxygen to the tissues will make the curve shift to the right, while all those factors that have increased affinity for oxygen and that binds to the oxygen will cause the curve to shift to the left. So let us look at the causes of right shift. Okay, so you can remember it by ABC bats right-handed. Sorry, ACE bats right-handed. So acid, CO2, exercise, right, all increasing. Then BPG, altitude and temperature. ठीक है, यहाँ पे everything is increasing, like increase in the H plus or increase in the POCO2, exercise, increase 2-3 BPG, high altitude and increase in the temperature. Now the factors that causes the left shift would be reverse of these conditions, but apart from that you need to remember three things, that is carbon monoxide, right, methemoglobin and HbF. These three have increased affinity for oxygen and therefore they will cause the curve to shift to the to the left. Okay. Now what is Bohr effect? It is that increase H plus from tissue metabolism shifts the curve to the right, leading to unloading of O2. Very simple. Okay. Increase in H plus will lead to oxygen unloading, causing the curve to the shift to the right. Now this is another curve which you just can go through. This is again the relation of PO2 to the oxygen bound to the hemoglobin given in ml per O2. Okay. So normally we can see that at 100% saturation the curve will follow saturation kinetics and it is a sigmoid curve like the oxygen dissociation curve. Now if we see that in anemia, what happens is that there is a decrease in the hemoglobin as we already studied. So the curve will decrease in amplitude, right? Basically 50% of hemoglobin is only available for binding with oxygen. So first the height will decrease, but it still is following the saturation kinetics, right? But in case of carbon monoxide poisoning, you can see the curve has shifted to the left, apart from decreasing in amount as well. Then the next topic we are talking about is the pulmonary circulation. So normally pulmonary artery has a low resistance, high compliance system, right? A decrease in PaO2 causes hypoxic vasoconstriction that shifts the blood away from the poorly ventilated region of lung to well ventilated regions of lung. There are two types of gases. First is perfusion limited gases. The examples are O2, CO2 and N2O. So what happens is that these gas equilibrates early, okay, along the length of the capillary, and the exchange can only be increased by increasing the blood flow. Okay, the blood flow increase करने पे exchange is increasing. That is why they are known as perfusion limited gases. This is very easy. Next are diffusion limited gases. Example of diffusion limited gases are O2 in fibrosis. Here it is given. Carbon monoxide. Right. So what happens is that these gases, they do not equilibrate by the time the blood reaches the end of the capillary. So O2 diffuses slowly while CO2 diffuses very rapidly across the alveolar membrane. Whenever there is a disease state that leads to diffusion limitation, right? For example, pulmonary fibrosis. in pulmonary fibrosis there will be diffusion limitation. First there will be hypoxia because oxygen is diffusing very slowly, and then there will be hypercapnia. Then chronic pulmonary vasoconstriction, it can lead to pulmonary artery hypertension, which may lead to cor pulmonale. Now diffusion, it is dependent on surface area, the thickness and the pressure gradient. If the surface area decreases, like in emphysema, the diffusion will also decrease. Right. If the thickness increases, like in fibrosis, again diffusion decreases. What is DLCO? DLCO is the extent to which the CO passes from the air sacs to the lungs, right? And this is also again important question. DLCO will be decreased in ILD, emphysema, pulmonary artery hypertension, and all the causes, all the factors that leads to decrease in the blood flow or decrease in the perfusion. While the factors that increases the DLCO are, the condition in which DLCO increases basically is asthma, polycythemia, right? So the next thing is pulmonary vascular resistance. It is given by the formula delta P by Q, which where it is delta P is the pressure gradient and Q is the flow, right? So resistance would be 8 multiplied by eta L upon pi r to the power 4. So basically it is dependent upon the viscosity, length of the vessel and radius to the power of 4. While if you see flow will be proportional to 1 by resistance, so it will be proportional to r to the power 4 divided by eta L, right? Or basically flow is proportional to r to the power 4 by L. Now this question, it was asked in INI-CET that 2 vessels are given. First is twice in length, I am not sure, and the diameter is D, and the second is L and the diameter is D by 2, maybe something like that was asked. So they asked what is the relation between the flow of the two. So if we use this formula, right, so flow 1 would be D by 2 to the power 4 upon 2L, right, and flow 2 would be equal to D by 4 to the power 4 upon L. Now this is D by 16 into 2L and this is into 16, I think it's 257. Yeah, so this is D by they won't give you such long calculations. I think I just did something wrong here. Yeah, upon L, right? So basically what I was trying to tell you is that to calculate the flow, you will just divide them. So it will be D by 16 into 2L divided by A. So this is 256 into L upon D. So D cancel. 16 16s are 2 8s are 16, right? So basically flow 1 will be 8 times of flow 2. This was the answer only, but I think here it was 2D and here it was D, something like that basically. Yeah, so that is how you calculate the flow problems. Next is the alveolar gas equation. It is given by the formula partial pressure of alveolar O2 is partial pressure of inspired O2 minus partial pressure of arterial CO2 divided by respiratory quotient. Respiratory quotient is CO2 produced upon oxygen consumed, right? And it is 0.8 for a mixed diet and it is 1 for a purely carbohydrate diet. Then alveolar arterial gradient, it is nothing but the difference in the partial pressure of O2 in the alveolar alveoli and the artery. Okay, capital A is alveolar and small a is artery. And the normal gradient is given by age by 4 plus 14. So the example that is given is, suppose a person is 40 years, right? So this will be 40 by 4 plus 4, that is 10, 14, right? So the AA gradient should be less than 14 for a person less than 40 years of age, right? Then what is the difference between these three terms, which are very confusing? Hypoxia, hypoxemia and ischemia, right? So hypoxia is decreased oxygen delivery to the tissue, right? So it can be caused by conditions like decrease in cardiac output. It can be caused due to hypoxemia, ischemia, both. Then anemia and carbon monoxide or cyanide poisoning. Hypoxemia, on the other hand, it is nothing but it is the decrease in partial pressure of O2 in the arteries, right? Now hypoxemia, it can be associated with either a normal AA gradient or a increase in the AA gradient, right? So basically this is type 2 respiratory failure. We will do it later. And this is type 1 respiratory failure. This question was again asked in 21 INI-CET. So increase in AA gradient is associated by either a mismatch between the ventilation and perfusion, in diffusion limitation conditions like fibrosis, and in right to left shunt. While a normal AA gradient would be seen in high altitude, right, or in cases of hypoventilation. Third is ischemia. This is nothing but this is loss of perfusion or loss of blood flow, right? And it can either be caused due to any obstruction in the arteries or due to decrease in the venous drainage. Then when talking about the ventilation perfusion mismatch, so ideally what should be the case, that ventilation should be equal to the perfusion, or the V by Q ratio should be 1, right? Here adequate lung exchange takes place. Now if we talk about moving from the apex to the base of the lungs, right, at the apex there is decrease in ventilation and perfusion, at the base there is increase in ventilation and perfusion. But what happens is that the decrease in perfusion at the apex is more than decrease in ventilation, which leads to an increase in V by Q ratio, while at the base the increase in perfusion again is more than increase in ventilation, which leads to a decrease in V by Q ratio. Okay, easy. With exercise what happens is that there is an increase in cardiac output that leads to vasodilation of the apical capillaries, and here the V by Q ratio approaches 1, right? Also remember that certain organisms that thrive in high O2 like TB, right, they will flourish in apices. So TB is more common in apices. Why? Because they require increase in O2, and at the apex the V by Q ratio is high. Therefore TB is found in apices despite of high ventilation and high perfusion at the base only. Easy. Now let us look at some conditions where V by Q is 0. V by Q 0 means that the ventilation is 0. Okay, ventilation 0 can be possible when there is any obstruction in the airway. So basically a foreign body, right? So here in these cases even 100% O2 will not improve the PaO2. Next is V by Q is equal to infinity. This means that the perfusion is 0. It can be seen when there is obstruction to blood flow as in cases of pulmonary emboli, right? Here the 100% O2 not improve, while here 100% O2 will improve the partial pressure of O2, right? Next is the transport of carbon dioxide. It is transported in three forms. The majority, that is approximately 70%, is in the form of bicarbonate ion, right? So in the RBC there is bicarbonate chloride exchanger, where chloride is taken up for loss of bicarbonate. This is known as chloride shift. Then second is carbaminohemoglobin, right? Only 25% of CO2 bound to hemoglobin, and remember it is bound at the N terminus. of the globin and not heme, while oxygen was bound to the heme, right? CO2 also favors deoxygenation from O2, right? We remembered ABC bats, ACE bats. So CO2 causes the right shift and unloading of O2, and then a very little amount of CO2, that is around 5%, is transported in the dissolved form, right? In lungs, the oxygenation of hemoglobin promotes the dissociation of H plus from the hemoglobin, right? So what is that oxygenation of hemoglobin? It causes dissociation of H plus from the hemoglobin. Due to this, the equilibrium is shifted towards CO2 formation. CO2 is formed and CO2 is released from the RBC. RBC release CO2. This is known as the Haldane effect, right? Bohr effect was unloading of O2, while Haldane effects is the release of CO2. Now in placenta, you can see double Bohr and double Haldane effects because there are two membranes. Okay, first maternal and placenta, then placenta and fetus. So here both double Bohr, that is O2 unloading, and double Haldane effects, that is CO2 release, takes place in placenta. Now the last points in physiology that is very important to know is the high altitude physiology and the exercise physiology. Okay, first let us see high altitude. So at high altitudes there is decrease in the partial pressure of O2, which leads to decrease in the partial pressure of arterial or O2, and that causes increased in the ventilation, leading to flushing of the carbon dioxide, right? Now flushing of carbon dioxide is called respiratory alkalosis, and this was a recent question again, 22 INI-CET. They asked which of the following is false about high altitude, and one option was respiratory acidosis, right? Why? Because respiratory alkalosis takes place due to increase in ventilation. Due to this, what happens is that there is altitude sickness, which is headache, nausea, fatigue, lightheadedness, right? In chronic cases or in chronically increase in ventilation, what happens is that it leads to increase in erythropoietin levels, which increases the hematocrit and the hemoglobin. Also there is increase in 2,3 BPG, which causes a right shift of the oxygen dissociation curve, leading to oxygen release, right? At the cellular level there is increased number of mitochondria because increased ATP needs to be produced. Also there is increased renal excretion of bicarbonate to compensate for the respiratory alkalosis, right? Also due to this fact, in cases of mountain sickness, the treatment can be acetazolamide because it pumps out bicarbonate, relieving the mountain sickness, right? Then chronic hypoxic pulmonary vasoconstriction, it can also lead to increase in pulmonary vascular resistance, leading to pulmonary hypertension and subsequently RVH. Okay, so this is basically what is seen in acclimatized or inhabitants of mountains. They have, if you go to Himachal Pradesh, you can see, or Ladakh, you can see kids with pink cheeks, which is due to increased erythropoietin causing an increase in hematocrit, right? Then exercise, what happens is that there is increase in cardiac output, right? Also there is increase in oxygen consumption. In exercise, we have already learned there is right shift of oxidation dissociation curve, increase in ventilation again to meet the O2 demand and remove the excess CO2. Then there is a VQ, the ventilation perfusion ratio from the apex to the base, it becomes more uniform, right? Increased pulmonary blood flow due to increased cardiac output. Then decreased in pH due to the production of lactic acid, like this is responsible for the fatigue we feel in the muscles after the exercise. Remember that there is no change in the partial pressure of O2 and partial pressure of CO2. There is increased definitely CO2 production and O2 consumption, but the partial pressure remains the same. But if you talk about the veins, right, there will be increase in CO2 and decrease in O2, but in arteries it is normal. So that completes the respiratory physiology. Okay, so now we are starting with respiratory pathology, and the first topic is rhinosinusitis. Right, so what happens is that there is obstruction of the sinuses causing inflammation and pain over the area. The most common sinus to be affected is the maxillary sinus. Why is that so? Because the drainage is against the gravity. As you can see in this picture, that the ostia is superomedial, right? Then on CT, it is identified as soft tissue density, which is homogeneous, right? That is sinusitis. The most common cause is viral, right? And the virus that is responsible is the rhinovirus. While there can be secondary bacterial infections, and the most common bacterial infection now is Streptococcus pneumoniae. Earlier it used to be H influenza, but due to vaccine coverage, now the important or the most common bacteria causing secondary infection is Streptococcus pneumoniae, and bacterial rhinosinusitis is usually unilateral, mucopurulent, and is associated with increased fever. The management of sinusitis is by medications for 1 month to suppress the infection, and after that the surgery can be done, which is FES, that is endoscopic sinus surgery. The most common complication of FES is hemorrhage, while the most dreaded complication is ICA hemorrhage. Right. Chronic complications can be mucocele, and the most common sinus in which mucocele takes place is frontal sinus. Then there can also be formation of pyocele. Now, what is Pott's puffy tumor? It is a subperiosteal abscess in the frontal sinus, right? It is not a true tumor, it is just an abscess, and it is treated by frontal sinus trephinization. The incision that is given is Lynch incision. Investigation of choice for Pott's puffy tumor is CEMR, because it is an abscess, so it will have heterogeneous peripheral enhancement. That is a characteristic of any abscess. The rhinosinusitis may extend to the orbits, leading to complications like superior orbital fissure syndrome, orbital apex syndrome, and it may extend into the brain and cavernous sinus, leading to meningitis, empyema, and cavernous sinus thrombosis. So how do you differentiate between all these conditions? Because in SOF syndrome, orbital apex syndrome, cavernous sinus thrombosis, all will present with proptosis, right? And it forms an important question because it is a correlation between ENT and ophtha. So in superior orbital fissure syndrome, it will affect 3, 4 and 6 cranial nerves, while in orbital apex syndrome, 3, 4, 6 cranial nerves will be infected along with the involvement of second cranial nerve, right? The most common intracranial complication is a subdural empyema more than a frontal lobe abscess. Cavernous sinus thrombosis, it will have sequential involvement of 6th nerve followed by 3rd and then 4th, and the most important point to remember is that there will be bilateral involvement. While a close differential for cavernous sinus thrombosis is orbital cellulitis, where just 3, 4, 6 nerves are involved, it is a gradual process and it is unilateral, right? This is very important. Then the drainage of sinuses. So if you see the lateral wall of nose, inferior meatus has the opening of nasolacrimal duct. In the middle meatus, there is frontal sinus, then anterior ethmoidal sinus and maxillary sinus, while in the superior meatus, the posterior ethmoidal sinus opens, right? So nasolacrimal duct in inferior, frontal, anterior ethmoidal, maxillary in the middle, and posterior ethmoidal in the superior. Then in sphenoethmoidal recess, the sphenoid sinus will drain. Remember that basal lamina is a plate that divides the ethmoid into anterior and posterior ethmoid. The next topic is epistaxis. Epistaxis is nothing but nosebleed, and it most commonly occurs in the anterior segment of the nostril. Why? Because of presence of Kiesel-Black plexus. So what they ask is the arteries forming the Kiesel back plexus, and you should be thorough with them. So the arteries are superior labial artery, greater palatine artery, sphenopalatine artery, and anterior ethmoidal artery. Remember, posterior ethmoidal artery is not a part of the Kiesel back plexus, and this question has been tested in previous exams. Now, they also ask like which artery is a branch of which artery, right? So anterior and posterior ethmoidal both are branches of ophthalmic artery, which is in turn a branch of ICA. Sphenopalatine and greater palatine both arise from maxillary artery, and maxillary artery is a branch of ECA, while ECA also gives rise to facial artery that gives a branch which is the superior labial artery, right? Then for management of epistaxis, first, a Trotter's method is used, in which the person is asked to bend forward, pinching his nose. If it doesn't work, then local cautery using silver nitrate can be done, followed by anterior nasal pack. Still no control in bleeding, then posterior nasal pack. And if still the bleeding does not stop, then we do ligation, which is the process is known as TESPAL, which is transendoscopic sphenopalatine artery ligation. Then anterior ethmoidal artery should be ligated. Still no control, then maxillary artery is ligated. Still no control, then ECA artery is ligated. Remember, ICA is never ligated, right? So this is an approach to epistaxis. The next topic is head and neck cancer, right? It is caused by HPV-16, that is mainly responsible for oropharyngeal cancer, while the Epstein-Barr virus is responsible for the nasopharyngeal cancers. Now, nasopharyngeal cancer, they usually present with otitis media or glue ear. So if you see glue ear in the history and the age is old, then the most likely diagnosis is a nasopharyngeal cancer. And if the history says it's a child, then the most likely cause is an adenoid hypertrophy. Now, nasopharyngeal cancer, most common site is the fossa Rosenmuller, and the risk factor are nitrosamines and Epstein-Barr virus. Then for screening, IgA or VCA can be done. This is sensitive, and EA antigen is a specific antigen for screening. Most common presentation of a nasopharyngeal cancer would be cervical lymph node mets, and the most important thing that you need to remember in this is the Trotter's triad. You can just remember it by NPC, where N stands for neuralgia, that is involvement of fifth nerve, P is palatal palsy, and C is conductive hearing loss due to glue ear, right? Then Trotter's triad is due to the superior spread, that is intracranial spread. It can also spread laterally to the parapharyngeal space, where it can cause Horner's syndrome. For management, right, we need to do biopsy, and WHO has two grades. First is a keratinizing squamous cell cancer. Second is divided into two, non-keratinized differentiated, and 2B is non-keratinized undifferentiated. Treatment of choice is CTRT. All right. So that was a little correlation with the ENT. Let us move to the next topic, which is deep vein thrombosis. It is basically a blood clot within a deep vein leading to swelling and redness. So what is Virchow's triad? Virchow's triad you can remember by the mnemonic SHE, where S is stasis, H is hypercoagulability, right, which can be due to defect in coagulation cascade proteins such as factor V Leiden mutation. This was asked in 2019 NEET, right? A use of OCP, and pregnancy is also a hypercoagulable state. Then E stands for endothelial damage, right, which exposes the collagen and it triggers the clotting cascade. Now, most pulmonary embolism arise from proximal veins of the lower extremity, like iliac, femoral, and popliteal veins. For diagnosis, D-dimer is used to rule out DVT, right? If the disease probability is low or moderate, then investigation of choice for DVT would be a Doppler. The management is, for prophylaxis, we can give unfractionated heparin, or low molecular weight heparin like enoxaparin, and for treatment direct oral anticoagulants like rivaroxaban and apixaban can be used for long-term treatment. Now when we are studying DVT, it is very important to know about the CEAP classification because it was asked twice last year. C0 is no visible disease, C1 is telangiectasia or reticular veins. Reticular veins are 1 to 3 mm while telangiectasia is less than 1 mm. C2 is the presence of varicose veins which is more than 3 mm. Telangiectasia, then reticular veins, and then varicose veins. And when varicose veins is present, it is C2. This was asked in NEET 21. Now 2R is a new category that is added where R stands for recurrent. C3 is the presence of edema. C4 is involvement of skin and subcutaneous tissue, right? C4A is when pigmentation or eczema is present. B stands for lipodermatosclerosis or atrophy blanche. Okay, B blanche. So this, and C for C, corona phlebitis, right? Also remember C3, 3 ka ulta E, so C3 is edema. That's how you remember. C5 is a healed ulcer, while C6 is an active ulcer, and C6 also has R, which stands for recurrent ulcer. Now the ulcer here is venous ulcer. Okay, venous ulcer is mostly present above the malleolus in the gaiter area, right? And it has shallow edges with exudate and sloughs, and the management for venous ulcer is Biscard regime, right? While arterial ulcer on the other hand will have a punched out appearance. It is deep and will have necrotic tissue, most commonly present over heel, right? While another type of ulcer is a neuropathic ulcer which will be present over the pressure points. It is a deep ulcer with no sensation present. Bed sore or neuropathic ulcer grading was asked this year in NEET, right? It is of 4 grades, 1, 2, 3, 4. So the answer was 4. They have shown a picture in which bone was visible. So if any underlying structures like bone are visible, it makes the stage 4, right? Investigation of choice we're talking about for DVT is Doppler. So on Doppler we can see the saphenous vein has an Egyptian eye appearance, right? Because the fascia surrounding it makes it look like an Egyptian eye. This is the vein. This is the fascia. Next, if you see in transverse plane, it gives a Mickey Mouse appearance, right? At the saphenofemoral junction. Artery is common femoral artery, the vein is common femoral vein, and the great saphenous vein drains into the common femoral vein, and this section gives the appearance of a Mickey Mouse appearance on ultrasound. On Doppler, you can see, suppose this is a normal vein. In case of DVT, an echogenic thrombus can be seen inside the vein. Next topic is pulmonary embolism. The DVT can lead to pulmonary embolism, and it is the obstruction of pulmonary artery or its branches by foreign materials, usually thrombus, that originates anywhere else, right? The affected alveoli are ventilated, but they are not perfused. So there will be a VQ mismatch. We already studied that the perfusion will be 0. So the VQ is usually infinity when the perfusion reaches 0. It presents with a sudden onset dyspnea, pleuritic chest pain, tachypnea, tachycardia, right? Increased heart rate, increased respiratory rate, hypoxemia, and respiratory alkalosis. Yeah, because respiratory rate is increased, so CO2 will be flushed out, leading to alkalosis. Then a large emboli, like here we can see, is known as a saddle emboli. On CT also you can see an emboli or a saddle emboli in this case as a hypodense filling defect in the pulmonary artery, right? I told you in CT this is the posterior part due to the presence of vertebra, right? This is the descending aorta, this is the ascending aorta, this is superior vena cava, and this is the pulmonary artery, and it is bifurcating into right and left branches. At the bifurcation we can see a hypodense filling defect in the pulmonary artery, and this is the saddle embolus, right? In the segmental or the branching also we can see hypodense filling defects. This is pulmonary embolism. Let me clear it for you. right? It's so easily visible on CT. Therefore, the investigation of choice is nothing but CTPA. That is, CTPA is nothing but contrast enhanced CT taken or acquired at early phases, right? So that pulmonary artery is opacified. You can see this is opacified. ECG, there is a characteristic appearance called as S1Q3T3. Everyone knows that, but remember this is only associated with massive pulmonary embolism. On histopath, we may see alteration of pink and red lines, which is known as lines of Zahan, and they are characteristic of an antemortem clot. And for treatment, first we need to know about the Wells score, right? Because this is also another score that is asked. So let us go through it quickly. Clinical sign of DVT gets a score of 3, and any alternate diagnosis less likely gets a score of 3, right? Baki others like heart rate, immobility more than 3 days or surgery within 4 weeks or any history of DVT, they all get a score of 1.5. Hemoptysis and malignancy get a score of 1 each. So if the score comes less than 2, then the probability of pulmonary embolism is low. If the score is 2 to 6, then it is a moderate, while more than 6, there is a high risk of pulmonary embolism. In modified Wells score, we just take one value. If the score is more than 4, then we say pulmonary embolism is likely. Treatment is again with anticoagulants like heparin, direct oral anticoagulants, factor 10A inhibitors, direct thrombin inhibitors, and if this does not work, then IVC filter can also, if this basically if anticoagulants are contraindicated, then IVC filter can also be put. Then the next topic is fat emboli. So fat emboli is usually associated with long bone fractures and even after liposuction surgeries, and it has a classical triad of hypoxemia, then neurologic abnormalities and petechial rash. This is the classical triad, and it is also diagnosed by Gird's criteria, and this was asked in this year NEET. So important. Then air embolism, it occurs due to the presence of nitrogen bubbles in deep sea drivers, right? That is known as Kyson's disease or decompression sickness. Treat with hyperbaric O2. This is primary air embolism. Secondary air embolism can be iatrogenic due to central line placement. Then amniotic fluid embolism, right? It typically occurs after labor or in postpartum, but it can also be due to uterine trauma, right? It can lead to DIC. It is rare, but the mortality is very high. Now, amniotic fluid embolism, this was also asked in this year's NEET, so this is also important. Like you can see that how many questions are asked just from a single slide. So yeah, it becomes important for revision. Moving ahead, mediastinitis and some mediastinal pathology. So basically mediastinitis is inflammation of the mediastinum. It is most commonly due to post-op complications of cardiothoracic procedures, and it occurs within 14 days post-op, right? It can be also secondary to esophageal perforation or some contiguous spread of infection from the retropharyngeal or the odontogenic areas. Then chronic mediastinitis, it is also known as fibrosing mediastinitis. Chronic is fibrosing mediastinitis, and it is due to the increased proliferation of connective tissue. The most common organism is Histoplasma capsulatum, and the clinical features are fever, tachycardia, leukocytosis. One important clincher in the history would be sternal wound drainage, right? So that's mediastinitis. Now pneumomediastinum is the presence of gas in the mediastinum. It can be spontaneous, which is due to the rupture of a pulmonary bleb, or secondary due to trauma, iatrogenic procedures, or Boerhaave syndrome. The clinical features are chest pain, dyspnea, voice change, subcutaneous emphysema, and Hammond's sign. On X-ray you can see ginkgo leaf sign if subcutaneous emphysema is present, while Hammond's sign is crepitus on cardiac auscultation. Now let us look at some flow volume loops. So first let us see the normal flow volume loop, right? You can see during expiration and during the inspiration. So this is expiration, right? This is inspiration, right? So this would be the total lung capacity, that is around 6 liters. After expiration, the volume, forceful expiration, the volume that is left is the residual volume, while this would be the vital capacity. Now what happens in obstructive lung disease, there is scooping up of the curve and it shifts to the left, that is there is increase in TLC and RV, right? So residual volume increases. In obstructive lung disease, FRC also increases and TLC also increases, while what happens is that FEV1 decreases, FVC decreases and FEV1 by FVC also decreases, right? This is like the characteristic of any obstructive lung disease. So if this is given on the pulmonary examination, then you can narrow it down to an obstructive disease. Now what happens in restrictive disease? Like see, there is shortening of the loop and it is shifting to the right. Shifting to the right means the volumes are decreasing. So the residual volume, FRC and the TLC will decrease. The FEV1 and FVC, they decrease, but the ratio is normal or it might be slightly increased. Now let us look at the obstructive lung diseases, right? The obstructive lung diseases are chronic bronchitis, emphysema, asthma and bronchiectasis. So first, chronic bronchitis, right? The patient would generally present with wheeze and there is cyanosis because of shunting that leads to hypoxemia and then cyanosis. Therefore the patient is usually known as a blue bloater. There may be carbon dioxide retention and secondary polycythemia as well. Retention and secondary polycythemia. Now on pathology, we can see hypertrophy and hyperplasia of mucus secreting glands. So a very helpful index in diagnostic chronic bronchitis is Reed index, which is the thickness of mucosal gland divided by thickness of the wall between the epithelium and the cartilage. A Reed index more than 50% is suggestive of chronic bronchitis. DLCO may be normal. Now how do we diagnose it? The clinical definition you can say is productive cough for more than 3 months in a year for more than 2 consecutive years. Then only you will say that the patient has chronic bronchitis. Second is emphysema. In emphysema, the patient usually has a barrel shaped chest, which means there is increase in the antero-posterior diameter of the chest. The expiration is prolonged through pursed lips and the patient is not in cyanosis and he is called as a pink puffer. Then it is of 3 types: centriacinar, paraseptal, panacinar, right? In centriacinar, it affects the respiratory bronchioles while sparing the distal alveoli. So you can see here the gross image, there are air spaces, while on CT also we can see black air spaces. Now normal lung field would be a little less black, but if it is having emphysema, then there will be cystic spaces which are more blacker than the normal lung parenchyma, and you can see that they are only up to the terminal bronchiole, hence it is centrilobular emphysema. In paraseptal emphysema, the blebs would be seen in the subpleural spaces, and if the blebs are seen in both subpleural and centrilobular spaces, then you call it as a panacynar emphysema. Now emphysema usually affects the upper lobe and it is most commonly seen with smoking. So you can remember it that smoke rises up, hence it is affecting the upper lobe. Right. Now this is true for centrilobular emphysema. In panacynar emphysema there is usually alpha 1 antitrypsin deficiency and here lower lobes are affected. So centriacynar smoking, hence upper lobe, panacynar alpha 1 antitrypsin, hence lower lobes. In emphysema the compliance is increased, we studied earlier, due to loss of elastic recoil, hence it is easier to fill up the lung, while DLCO it will decrease. Why? Because of destruction of alveolar walls. In the histopath also we can see that due to increased elastis there is destruction of the alveolar wall and there are cystic air spaces replacing the alveoli. That is characteristic of emphysema. The CD8 plus cells along with neutrophils and macrophages are increased. Next condition is asthma. What mucus plugs can be seen here? This is a mucus plug on histopath. The severe attack may also lead to pulsus paradoxus, triggers being viral URI, allergens or stress. Then in asthma the bronchi are hyper-responsive, which is the reason for smooth muscle hypertrophy and hyperplasia. On histopath we can see 3 C's, which is the Kirschmann spirals here, right? Charcot Leyden crystal. Kirschmann spiral, it is a shed epithelium forming a whorled mucus plug. Then Charcot Leyden crystal, it is an eosinophilic hexagonal double pointed crystal formed from the breakdown of eosinophils in the sputum. Kirschmann spirals and Charcot Leyden crystal. The third C is a Crayola body. Then it is a type 1 hypersensitivity reaction and it is diagnosed by spirometry, right, and methacholine challenge test. Now in asthma the DLCO may be normal or it is increased, and Samtus triad is associated with it, which is basically aspirin sensitivity, chronic sinusitis with polyps and asthma. So this question was again asked this year in NEET, where they had asked about the aspirin sensitivity, right. Then the fourth is bronchiectasis. So here there is daily purulent sputum production and there is recurrent infection. The most common organism involved is Pseudomonas and there is also clubbing present. Then it is basically a chronic necrotizing infection and there is permanent damage to the airways. Bronchiectasis, it is associated with Cartaginer syndrome, right, where there is poor ciliary motility. It can also be associated with cystic fibrosis. It appears as dilated airways. You can see this is cylindrical bronchiectasis. In children, another variant can be cystic bronchiectasis, where you can see cystic spaces, right. And another type of bronchiectasis is varicose bronchiectasis, which is very rare. Most commonly you can see cylindrical or cystic bronchiectasis. Also there is a type of bronchiectasis known as traction bronchiectasis, which is associated with ILDs, which we will see a bit later. Then those were the obstructive lung disease. Now let us start with the restrictive lung disease, right. So in restrictive lung disease there is decrease in lung volumes while the PFT is normal, that is FEV1 by FVC normal, or it may be slightly increased, right. Now it can be differentiated into two types, one due to altered respiratory mechanism and two, that is the diffuse parenchymal lung disease, which we commonly call as the ILD or the interstitial lung disease. It is based upon DLCO and AA gradient. So if the DLCO is normal and the A gradient is normal, then we say that it is most likely an altered respiratory mechanism. like weakness of respiratory muscles, as we can see in polio, myasthenia gravis, Guillain-Barré syndrome and ALS, while there can also be chest wall abnormalities like in scoliosis and severe obesity. Coming to the DLPD or ILD, here there is decrease in DLCO with increased in AA gradient. Right, the types of DLPD is first radiation induced lung injury. It is associated with pro-inflammatory cytokines like TNF alpha, IL-6, IL-1. It can be of two types, acute and chronic. Acute develops in 3 to 12 weeks, right, and here there is exudation, while chronic radiation fibrosis takes 6 to 12 months to develop, and here fibrosis takes place. Then idiopathic pulmonary fibrosis. It is a progressive fibrotic lung disease where the etiology is not known, therefore we say idiopathic, and it involved multiple cycles of lung injury, inflammation and fibrosis. Now on clinical findings, we can hear bilateral basal creps, clubbing can also be seen, and on CT you can see the characteristic honeycomb appearance, that is peripheral reticular opacity along with traction bronchiectasis. So bronchiectasis due to fibrosis is called traction bronchiectasis. The histopathological pattern of IPS is known as UIP or the usual interstitial pneumonia. The next type of ILD is NSIP, where there is diffuse ground glass appearance, but you can note that there is subpleural sparing, right. This is very similar to COVID CT. In COVID also there is diffuse ground glass appearance with interlobular septal thickening plus GGO, but the difference between NSIP and COVID is that NSIP you can see it's very diffuse with subpleural sparing, while in COVID there is characteristic involvement of the subpleura space with discrete opacities, right. You can see patchy discrete opacities with involvement of the subpleural space. So this is a CORAD 5 characteristic of COVID. Next is hypersensitivity pneumonitis. It is a mixed type 3 type 4 hypersensitivity reaction and is seen in farmers and bird carriers. Now the best part is it is self-remitting, you just need to stay away from the stimuli. If there is chronic exposure, then it may lead to irreversible fibrosis with non-caseating granulomas, right. Next topic is sarcoidosis. Sarcoidosis, it is an immune mediated reaction in which there is again non-caseating granulomas. Sarcoid, the granulomas are also called as naked granulomas. Why? Because a collar of lymphocytes around the granuloma is usually absent. It is associated with increased CD4 counts, right. Remember emphysema was associated with increased CD8, but in sarcoidosis the CD4 is to CD8 ratio is increased. Second, there is hypercalcemia, and third, increased ACE. So wherever you see increased ACE and hypercalcemia, the diagnosis usually goes in the favor of sarcoidosis. Now the staging or grading of sarcoidosis is by SCADing criteria, where 0 is no involvement. In grade 1 there is involvement of lymph nodes, grade 2 is involvement of lymph nodes and parenchyma. Here you can see on the x-rays bilateral lymph nodes are involved along with coarse reticular opacities, that is characteristic of sarcoidosis. If you see it on CT, you can clearly see the peribronchovascular nodules, which are characteristic of sarcoidosis, along with bilateral hilar lymphadenopathy, right, and these centrilobular nodules, which are perivascular. Stage 3 is involvement of only parenchyma, and stage 4 is fibrosis. So, this is SCADing criteria. Then sarcoidosis is associated with, this was the question that was asked this year 22 NEET again, that it is associated with Bell's palsy, uveitis, lupus pernio. Then some histopath features are the presence of asteroid bodies and Schaumann bodies. Schaumann bodies are basophilic bodies, right. Sarcoidosis can also be associated with erythema nodosum, rheumatoid like arthropathy, etc. One more point I forgot to tell you, the hypercalcemia in sarcoidosis, this is because of increased 1-alpha hydroxylase produced by the granulomas that increases the vitamin D production that is responsible for hypercalcemia. For management, we give steroids only in symptomatic cases. Next is inhalational injury. Now, inhalational injury is usually caused by a noxious stimuli like smoke, and it can only be caused by particulates which are less than 1 micron in diameter. It can also be caused by irritants like NH3, like that leads to chemical tracheobronchitis, edema, and even ARDS. Now, what do we find, or what is the sequelae of an inhalational injury? So, within 18 hours, you can see soot particles in the oropharynx, right? But after 11 days, you can see there is no soot deposition and there is clearing of the passages. So, that is an important finding. Also, a clincher which will be given is singed nasal hair, which points towards an inhalational injury. So, the next topic is pneumoconiosis. Pneumoconiosis usually involve the upper lobe except for asbestosis, in which the lower lobe is involved, right. So, let us start doing pneumoconiosis one by one. So, asbestosis is due to amphibole or crocodile more than chrysolite, right. It is associated with the pleural diseases, malignancies, and it causes ivory white calcified subdiaphragmatic plaques or subpleural plaques, see here. And these subpleural plaques, which on X-ray appears as holly leaf appearance, are pathognomic of asbestosis. Now, in asbestosis, the risk of bronchogenic carcinoma, right, the risk of bronchogenic carcinoma is more than the risk of mesothelioma, but the most common cancer caused by asbestosis is mesothelioma. It also has increased risk of Kaplan syndrome, where there is rheumatoid arthritis with pneumoconiosis and intrapulmonary nodules. Due to nodular pleural thickening, mesothelioma can also lead to the presence of frozen hemithorax, right. Also, on histopathology, we can see these elongated brownish bodies which are known as ferruginous bodies or asbestos bodies, right. They are golden brown fusiform rods and they resemble the dumbbells. They are found in the alveolar sputum sample and they can be visualized by the Prussian blue stain in the bronchioalveolar lavage. Then let us talk about mesothelioma here only. Tobacco smoke is not a risk factor for mesothelioma, right. Asbestosis is a risk factor. In mesothelioma, the marker is calvitatin and cytokeratin 5 and 6. It has long and slender microvilli which helps it to differentiate from adenocarcinoma, which has short and stumpy microvilli. This can be seen on electron microscopy image. Then mesothelioma may lead to hemorrhagic pleural effusion and pleural thickening. On histopath, there may be presence of sarcoma bodies. Right? That was like a mesothelioma in a gist. Then the next pneumoconiosis is berylliosis. It is usually seen in people working in jewelry or dental alloy, and berylliosis mimics sarcoidosis, right? Because of the presence of non-caseating granulomas. It increases the risk of cancer and core pulmonary. Next is coal-workers pneumoconiosis. So, it is associated with Erasmus, which is coal-workers pneumoconiosis with systemic sclerosis. Then it is usually due to prolonged coal dust exposure, due to which there is formation of carbon-laden macrophages, which leads to inflammation and fibrosis. Right. The condition caused by coal is anthracosis, where we can see black deposits in the lung here. So, if we see brown deposits in the histopath of lung, how do you identify a lung or an alveoli? By the presence of these air spaces, right? If brown is present, then it is usually a heart failure cell, and if black is present, this is anthracosis. This image was asked in 21 NEET. Right? Now, the form responsible for coal-workers pneumoconiosis is anthracite more than bituminous. It affects the upper lobe, and on imaging there can be small round nodular opacities, which helps in making a differential. The next is silicosis. It also affects the upper lobe and it increases the risk of TB. It is usually seen in people working in sandblasting or foundries and mines. Like the macrophages, they respond to cilia and they release fibrogenic factors leading to fibrosis. On chest X-ray, eggshell calcification of hilar lymph nodes is characteristic of silicosis. Then some other ILDs are byssinosis, which is due to cotton and it leads to Monday chest tightness. Now, like just related to Monday chest tightness is byssinosis, while Monday morning sickness is due to nitroglycerides, because they are venodilators and they decrease the preload leading to Monday morning sickness, while Monday morning fever, which is also known as malarial chills, is due to zinc poisoning, right? Then metallic ILD, it is caused due to siderosis, that is iron, barytosis, barium, and stanosis, that is tin, and copper, it leads to granulomatous ILD, that is some extra edge that you should know. Also, another metal, that is cobalt, it is associated with giant cell interstitial pneumonitis, right? The next topic is ARDS. It is basically due to alveolar insult that leads to the release of cytokines, right? And subsequently there is neutrophil recruitment and activation of reactive oxygen species and proteases, causing endothelial damage and increasing the vascular permeability, that in turns lead to leakage of protein rich fluid and the formation of hyaline membrane. Remember, we read about NRDS, that is the neonatal respiratory distress syndrome. It is also due to the hyaline membrane formation, which was due to deficiency of surfactant, and here there is injury to the lung leading to the formation of hyaline membrane, right? The most common cause of ARDS is sepsis. Other causes can be aspiration, pneumonia, trauma, and even pancreatitis. For diagnosing ARDS, there should be abnormal chest X-ray, right? What we'll see bilateral diffuse opacities which are usually asymmetrical, right? In pulmonary edema, we see symmetrical opacities, right, that leaves that spares the apices of the lungs. Hence, they are also known as battering opacities. While in ARDS, we see diffuse opacities, even the apices are involved, but it can be asymmetrical. Also remember that ARDS is also known as non-cardiogenic pulmonary edema, while the condition which we refer to as pulmonary edema is usually cardiogenic. Okay. So this question was asked again, that an image of this battering appearance was shown and pulmonary edema was the diagnosis. They asked how will you manage, so the management will be IV nitroglycerin. Okay. Then this was A. R stands for respiratory failure type 1 within 1 week of insult, right? D is decreased PaO2 by FiO2, which is less than 300, and S stands for symptoms of respiratory failure which are not due to heart failure or fluid overload. So due to the formation of hyaline membrane, what will happen? There will be impaired gas exchange, decreased lung compliance, and subsequently pulmonary artery hypertension. So for treatment, the underlying mechanical cause should be treated, and the mechanical ventilation is very important, right? They always ask this question. It is a low tidal volume, high PEEP ventilation. High PEEP is used to keep the alveoli open even during expiration, right? The histopath finding of ARDS is very characteristic. See, this is an alveoli, because of the cystic spaces, and you can see the deposition of hyaline membrane. See, again here hyaline membrane is deposited. So that is ARDS for you, and along with its histopath correlation. The next topic is sleep apnea. So sleep apnea is of 3 types: obstructive sleep apnea, central sleep apnea, and Pickwinian syndrome. So obstructives, first of all, let's define sleep apnea. It is repeated cessation of breathing for more than 10 seconds during the sleep, causing disrupted sleep and therefore increased daytime somnolence. Then it can lead to pulmonary hypertension, right, which in turn can also lead to arrhythmias and sudden death. Now obstructive sleep apnea, here remember, very important point is that the PaO2 is usually normal during the daytime. It is usually associated with obesity, snoring, and daytime sleepiness. Central sleep apnea, on the other hand, it is due to some CNS injury or insult. It can be due to congestive heart failures or opioids, right? It is associated with Stokes respiration, which is oscillation of hypernia and apnea, right? This is Stokes respiration. Treatment for obstructive sleep apnea is by giving the patient CPAP and asking him to lose weight, that is lifestyle modification. Some trial treatments of hypoglossal nerve stimulation have also been tried, while in central sleep apnea, the management is by giving the positive pressure airway, positive pressure ventilation. Then Pickwinian syndrome, this is the obesity hypoventilation syndrome. Here the BMI of the patient is more than 30 kg per meter square, which leads to hypoventilation. And very important is that there would be increased PaCO2 during the daytime as well, right? While during the sleep there will be increased PaCO2 along with decreased PaO2. So obstructive sleep apnea and Pickwinian both are associated with obesity, but in obstructive sleep apnea the partial pressure of O2 is normal during the daytime, while in Pequinian it is the partial pressure of CO2 is increased during the daytime, along with increased partial pressure of CO2 and decreased partial pressure of O2 during the night time. The treatment is again weight loss along with positive pressure ventilation. Then the next topic is pulmonary hypertension. Right, it is increased pulmonary artery pressure more than 20 mmHg at rest. It results in arteriosclerosis, hypertrophy, and it can lead to increased pulmonary vascular resistance, leading to increased right ventricular pressure, which causes right ventricular hypertrophy and subsequently right ventricular failure, which is cor pulmonale. Then the causes of pulmonary arterial hypertension are first pulmonary arterial hypertension. It is mostly idiopathic, right? Females are more commonly involved. This is due to a mutation of BMPR2 gene. Right, so what this gene does, it basically inhibits the vascular smooth muscle proliferation. So if there is a mutation, there is increased proliferation of the vascular smooth muscle, causing increased vasoconstriction due to endothelin and decreased vasodilator due to nitric oxide and prostacyclins. Then second is left heart disease. It causes systolic and diastolic dysfunction and valvular diseases. Right. Third are lung diseases or hypoxia. Here what happens is that there is destruction of lung parenchyma due to suppose say COPD, right, or inflammation in ILD, and this leads to hypoxemic vasoconstriction. Then chronic pulmonary embolism, there is recurrent microthrombi that decreases the cross-sectional area. And then multifactorial causes are hematological causes, then systemic, metabolic, or compression by a tumor, etc. That completes pulmonary hypertension. Now let us look at some physical findings, because these are the basic questions. You must know about them. We are just revising them quickly. Okay. So what happens in pleural effusion? In pleural effusion, the bronchial breath sounds decreases, percussion would be dull, vocal fremitus also decreases, and tracheal deviation would be away from the lesion or contralateral tracheal shift. In atelectasis, again decrease, dull, decrease focal fremitus. The difference is that it will be towards the lesion, or ipsilateral, that is the deviation of trachea. In pneumothorax, which is a simple pneumothorax, the breath sounds decrease, but on percussion we can hear a hyper resonant sound because of increased air. Vocal fremitus is decreased and there is no tracheal deviation. While in tension pneumothorax, everything would be same as simple pneumothorax, associated with a contralateral tracheal shift. In consolidation, that is lobar pneumonia and pulmonary edema, we can hear bronchial breath sounds, right, late inspiratory crackles, egophony, and whispered pectoralici. The percussion is dull, vocal fremitus here increases, and there is no tracheal deviation. The next physical finding that is very important is clubbing, right? What happens is that there is increased nail bed angle, which is also called the Lovibond angle, more than 180 degrees. So what is speculated is that there is an intrapulmonary shunt, right, where platelets and megakaryocytes are lodged in the digital vasculature. That leads to increased platelet derived growth factors and vascular endothelial growth factors, that leads to the increase in the angle. Now what are the causes of digital clubbing? You can remember it by the mnemonic clubbing itself, where C is congenital heart disease, L is lung infections, lung abscess and lung infections like TB, even lung cancers. Then U for ulcerative colitis, especially IBD, B bronchiectasis, I IPF, N is very important, it is not associated with COPD and asthma, right? Next topic is atelectasis. Atelectasis is nothing but it is collapse, right? So here if you see on the x-ray, there is a homogeneous opacity in the right upper lobe and the trachea is shifted ipsilateral. So this is nothing but this is a right upper lobe collapse. So there are four types of collapse. First is obstructive collapse. It is due to the presence of a foreign body, right, that leads to collapse of the lung. Compressive collapse is due to an external or a pleural disease like a space occupying lesion, pleural effusion, pneumothorax. Then contraction or cicatricial collapse, it is due to scarring, that is sarcoidosis. And finally adhesive collapse, which is seen in NRDS in premature babies. Next is pleural effusion. Pleural effusion is the excess of accumulation of fluid in between the pleural layers that causes restrictive lung expansion, right? It can be treated by thoracocentesis. So here we can see that there is obscured diaphragm and there is obliteration of CP angle, which is most likely pleural effusion. It is better seen on CT, and it is treated by thoracocentesis. Right, you can see the angle has cleared. Compare it with this picture. This is the same patient. Here there was blunting of CP angle, and here the CP angle is clear. Right, even on CT you can see the fluid has decreased drastically in size in post thoracocentesis. For diagnosis of pleural effusion, Light's criteria is used, which has three things. First is pleural fluid protein upon serum protein ratio should be more than 0.5. Then pleural fluid LDH divided by serum LDH more than 0.6, and pleural LDH should be more than 2/3 the upper normal limit of serum LDH. Based on this Light's criteria, pleural effusion is divided into two types: the exudative pleural effusion and transudative pleural effusion, right? So in exudative there will be leakage of fluid and proteins, and it is seen with cancer, infection and trauma, while transudative is usually due to increase in hydrostatic pressure in conditions like heart failure and sodium retention, while it can also be used to decrease colloidal pressure in conditions like nephrotic syndrome and cirrhosis. Finally, lymphatic pleural effusion, it is also known as chylothorax, right? So it happens due to injury to thoracic duct, trauma or malignancy. Then on aspiration or pleural tap, we will see milky white fluid which is high in triglycerides. This is very important. This is asked that chylothorax is rich in what? That is triglycerides. Next is pneumothorax. So pneumothorax is asked every year in every exam, and it is very important. Right. What is pneumothorax? It is accumulation of air in the pleural space. So how do you say this is a pneumothorax? See, you can see the lung, right? This is air, this is air. So there is hyperlucent lung along with a visceral pleural line. On the X-ray again we can see hyperlucent lung feed along with a visceral pleural line representing a collapsed lung, right? This is pneumothorax. So pneumothorax can be either a spontaneous, traumatic or tension pneumothorax. Spontaneous pneumothorax can be primary, which is due to the rupture of apical blebs or cysts, right? It is associated with tobacco smoking. Secondary spontaneous pneumothorax is due to a diseased lung, right? There can be either emphysema or Marfan, or even in cases of barotrauma. Then traumatic pneumothorax, it is caused by blunt trauma, that is a fracture of rib, or by penetrating trauma like a gunshot. Even iatrogenic trauma like central line placement, lung biopsy can also lead to traumatic pneumothorax. Then tension pneumothorax, it can be due to any of the above causes. But what happens is that suppose this is the lung, right, and this is the pleura. So what happens is that the air can enter but it cannot leave. So there is a ball valve mechanism due to which air is trapped inside, causing increased in the tension, or that is why it is called a tension pneumothorax. Due to massive increase in air, it pushes the trachea to the opposite side, causing a contralateral tracheal shift. Right. It may lead to increased intrathoracic pressure, which can also lead to kinking of IVC. Right. Due to this, there would be decreased venous return, hence decreased cardiac output, and finally it leads to obstructive shock. Right. So what would be the features of obstructive shock? Decreased BP, decreased heart rate, and increased JVP. For management, you need to place, management is very important, this is asked every time. You need to place needle in the 5th intercostal space, followed by ICD underwater seal again in the 5th intercostal space in triangle of safety. Okay, boundaries are pectoralis minor, latissimus dorsi, and this is the 6th rib. Latissimus dorsi, pectoralis minor, 6th rib, right? And the only where this answer will change would be a child. In a child, you place the needle in 2nd intercostal space, followed by ICD again in the 5th intercostal space. So that is the management of pneumothorax, right? Here you can see in the X-ray that there is pneumothorax along with contralateral tracheal shift. So this is an example of a tension pneumothorax. While in this case, if you see, the trachea is midline and there is pneumothorax, but this is not tension pneumothorax, this is a simple pneumothorax. Right. Let's move to the next topic, which is pneumonia. So pneumonia is of 4 types: lobar pneumonia, bronchopulmonary, interstitial, and cryptogenic organizing pneumonia. Let us look at them one by one. In lobar pneumonia, the most common organism is Streptococcus pneumonia, right, Legionella and Klebsiella. Here you can see that there is intraalveolar exudate which leads to consolidation. Consolidation is nothing but homogeneous or inhomogeneous opacity in the lung field. Okay. Right. So here we can see there is a homogeneous opacity in the right mid and lower zones, right middle zone and right lower zones, right. Also, if you see the gross, you can see that there is involvement of only one lobe, hence it is called as lobar pneumonia. On chest X-ray, don't confuse zones with lobes, right. For example, why I am saying this is because on antero-posterior view in X-ray, this can be lower lobe also and this can be middle lobe also, because middle lobe is anterior and lower lobe is posterior, but they are antero-posteriorly, they are overlapping, right. So in X-ray on APV, we don't use the terms as lobes, we use the terms like zones, right middle zone, right lower zone. This does not mean that there is involvement of many lobes, there is involvement of one lobe only, that is why it is lobar pneumonia, right. You can clearly see on the gross image. Then bronchopneumonia, here also the most common organism is Streptococcus pneumoniae. Other organisms are staph, Haemophilus influenza and Klebsiella. Here on histopath we can see infiltrates, right, from bronchioles into the alveoli, and there is patchy involvement of the lungs, therefore more than one lobe can be involved. Next is interstitial pneumonia, which is also called as atypical pneumonia, and the most common organism is mycoplasma, followed by chlamydia, right? Then it can also be caused due to viruses like RSV and CMV. Now the mycoplasma causes walking pneumonia because the course is quite indolent, and on X-ray we can see the pneumonia is in the form of inhomogeneous interstitial opacities. Right. Then the final type of pneumonia is a cryptogenic organizing pneumonia, which was earlier called as bronchiolitis obliterans organizing pneumonia. The etiology is unknown because the sputum and blood cultures are usually negative, right? But they often respond to steroids. So here, what can be seen on CT? We can see the atoll sign or a reverse halo sign. Okay. What is reverse halo sign? That you can see GGO in between and surrounded by a rim of consolidation, right? This is a characteristic of COP or COP, and it is also seen in COVID. In COVID, halo sign can also be seen. Halo sign is consolidation in between, in the center, with GGO all around. This is halo sign. Now let us look at the pathology of pneumonia briefly. So in the first few days there is congestion, right? And the exudates, the alveoli contains exudate and the bacteria. The second stage is red hepatization, where the alveoli would contain RBC and fibrin. In the phase of grey hepatization, the RBC are replaced by lysed RBC, WBC can also be present, and exudate. Finally, after 8 days, there is the stage of resolution, and there is enzymatic degradation of exudate by macrophages, right? Yeah, so there is very less exudate. Here you can see the exudate is so much, there is no exudate here. So those are the stages or the pathological stages of pneumonia. The next topic we're doing is lung abscess. So abscess is nothing but it is a localized collection of pus, right? It can be caused by aspiration of oropharyngeal contents, especially in patients who have loss of consciousness or alcohol overuse, even epilepsy, right? So what we can see is that here the gross is showing the abscess, which is a localized area of pus collection. On X-ray it appears as a thick walled cavity with an air fluid level, right? If you see the same thick walled cavity and an air fluid level with some thing like this is Waterlini sign of hydatid cyst. Don't confuse it with an abscess, right? Now the most common organism that causes the abscess are anaerobes. The examples of anaerobes are bacteroids, which everyone knows. The other examples are Fusobacterium and Streptococcus. This was asked 21 NEET, right? Then lung abscess secondary to aspiration are most commonly seen in the right lobe. Why? Because the right bronchus is longer and it is more vertical than the left bronchus. So what are the positions? Suppose if the patient is upright, then the most common lobe involved is the right lower lobe, while if the patient is supine or recumbent, then right middle lobe or right upper lobe are more commonly involved, but the most common would be the apical segment of right middle lobe in supine position, right? Then the next topic we're doing is lung cancer. So lung cancer are of two types broadly: non-small cell cancer and small cell lung cancer. So let us start with small cell lung cancer. It has hematogenous mets. It is central. The gene involved is very important, LMIC, right? Then on histopath we can see Kulchinsky cell. What are Kulchinsky cell? These are small round blue cells here, and they show azopardy effect and salt and pepper chromatin. Okay, so they have like this appearance, salt and pepper chromatin. This is characteristic not just of small cell cancer of lung but all the neuroendocrine tumors, right? Because small cell cancer is a neuroendocrine tumor. Since it's a neuroendocrine tumor, it will be positive for these three things, which is NSE, synaptophysin A and chromogranin. Then the other IHC markers are bombicin and CD56 and CD57. Then it is associated with increased ADH causing SIADH, ACTH leading to Cushing syndrome, antibodies to presynaptic calcium channels causing Lambert-Eaton myasthenia syndrome, or it can have antibodies to neurons, that is the anti-WHO antibodies leading to encephalomyelitis. Now this is very important. What are the causes of paraneoplastic cerebellar degeneration? We've read anti-WHO antibody is seen in lung cancer, then anti-EO antibody, it is seen in gynae and breast cancer, and finally anti-TR antibody seen with Hodgkin's lymphoma. This question was also indirectly asked in NEET. They had given a case of seminoma with the ataxia. Hodgkin's lymphoma was the answer, I think, because it is a paraneoplastic cerebellar degeneration due to anti-TR antibody. Next is adenocarcinoma. It is associated with non-smoking females, right? Then the characteristic of adenocarcinoma, it spreads along the bronchus, which is known as a lipidic spread, and it is peripheral. The genes involved are EGFR, KRAS and ALK. On histopath we can see the gland formation or the glandular pattern, right? The glandular pattern which stains for mucin positive, right? The IHC markers are TTF1 and napsin A. Then the paraneoplastic syndrome associated are Troju syndrome, which is migratory thrombophlebitis, HPOA, which is periosteal thickening in the digits, and the clubbing. Then the next is squamous cell cancer. This is the most common cancer in India. It is associated with Pancreas tumor. It is central, and it appears as a hilar mass, as we can see on this X-ray. The gene is P53. On histopath we can see keratin pearls, right? This is characteristic of any squamous cell cancer, the presence of keratin pearls and intercellular bridges, that is the desmosomes. Then the IHC markers are P40 more than P63. The most common paraneoplastic syndrome is hypercalcemia due to parathyroid hormone related peptide. Then it is associated with Pancreas tumor, right? Pancreas tumor is a tumor of apex of the lung, right? It is also known as a superior sulcus tumor, and it causes Pancreas syndrome due to the compression of the following structure. First is the recurrent laryngeal nerve. This will lead to hoarseness. Then stellate ganglion would lead to Horner syndrome. SVC obstruction would lead to SVC syndrome, right? Then brachiocephalic vein compression leads to unilateral brachiocephalic symptoms. Brachial plexus compression will lead to shoulder pain and sensory motor deficits, and then phrenic nerve compression leads to hemidiaphragmatic palsy. Right? On chest X-ray it would present by elevation of that side of the diaphragm. Superior vena cava syndrome, it is basically due to obstruction of the superior vena cava due to some clot or Pancreas tumor, as we just studied. So what happens is that there is improper drainage of blood from the head, right? That leads to facial plethora. Here we can see that on pressing the upper chest with the fingers, there is blanching due to the presence of SVC syndrome. Then there is improper drainage from the neck leading to jugular venous distension, right? Also there is upper extremity edema. It is usually a medical emergency as it can lead to increased ICP, right, causing headache, dizziness, and it leads to increased risk of aneurysmal rupture of intracranial arteries. The last type of cancer is a large cell tumor. So you just need to know the histopath, which is characterized by giant cells, right, and the paraneoplastic syndrome associated is gynecomastia due to increase in HCG. So these are all the lung cancers in one page. It's beautifully given. You can revise it multiple times. The most important points to know are the paraneoplastic syndromes. Let us revise them again quickly, right? With a small cell, there is SIDH, Cushing, LEMS, and encephalomyelitis due to anti-WHO antibodies. With adenocarcinoma, Trochu syndrome, HPOA. With squamous cell carcinoma, it is hypercalcemia due to parathyroid hormone related peptide protein and Pankos tumor, and with large cell cancer it is gynecomastia due to HCG. That completes the pathology, and now we'll be moving ahead to RESPI pharmacology. So finally we'll be doing the last part of the respiratory system, that is the pharmacology. And let us start with the H1 blockers or antihistaminics, right? So the reversible inhibitors of H1 histamine receptors are called as antihistaminics, and they function as either neutral antagonist, right, antagonist, or inverse agonist. Okay, so the first generation, you can remember that the name usually contains either N or IN, right, or N or 8. So let us look at the examples and see it clearly. So the first drug is diphenhydramine, right, N and IN. Second is dimenhydrinate. This is an example of N and 8. Similarly, the other drugs are chlorpheniramine, right, and doxylamine. So they are basically used in allergy, motion sickness, vomiting in pregnancy, etc. The adverse effect is sedation, right? Side effects is sedation, and they have anti-alpha adrenergic and anti-muscarinic side effects. If you remember, in antipsychiatric drugs, we see that usually the HAM side effects goes together, right, which is histaminic, alpha, and antimuscarinic. So again, antihistaminics will definitely have these side effects, right, HAM side effects. Next are second generation antihistaminics. They have names that usually ends in adine, right. For example, loratadine, fexofenadine, etc. The only exception is cetirizine, which is a second generation antihistamic without adine at the end. Then they are also used for allergy, but the advantage is that the sedation is far lesser than the first generation because of less entry into the CNS. Then the next drug is dextromethorphan. it is an antitussive and it is NMDA antagonist, right? It is a synthetic analog of codeine and hence has a mild opioid effect when used in action. So if there is overdose of dextromethorphan, you know what drug will give? Naloxone, because naloxone is used in opioid overdose. This question was asked in again this year, or INI, one of the two, right? Then dextromethorphan, it has a mild abuse potential. It may cause serotonin syndrome if mixed with other serotonergic agents. Pseudoephedrine and phenylephrine, right? You can see epinephrine derivatives, so they are alpha adrenergic receptor activators, right? And they cause local vasoconstriction in the nasal mucosa. So what are they used for? They are used for decreasing the hyperemia and edema and used as nasal decongestants, right? They are also useful in cases of blocked eustachian tubes. They open the blocked eustachian tubes. The adverse effect is, since they are adrenergic activators, they can cause hypertension and also rebound congestion, which is known as rhinitis medicamentosa. This is important because it is a correlation with ENT, medicamentosa, right? When it causes rhinitis medicamentosa, if it is used for more than 4 to 6 days, then it is associated with tachyphylaxis and it can cause CNS stimulation or anxiety, right, due to the alpha receptor. Then some drugs for pulmonary arterial hypertension. The first is endothelin receptor blockers. The example is bosentan, right? What it does, is that it competitively inhibits the endothelin receptor, causing a reduction in pulmonary vascular resistance, right? The adverse effect is that it is hepatotoxic, hence it requires LFT monitoring. Then phosphodiesterase 5 inhibitors, what they do is that they increase the cGMP, which causes prolonged vasodilatory effect of nitrous oxide, right? The example is sildenafil. They are also used to treat erectile dysfunction. The important point to note, it has a drug interaction with nitroglycerin and other nitrates due to the risk of severe hypotension, right? Phosphodiesterase 5 inhibitor and nitroglycerins are contraindicated, should not be administered together. Important drug reaction. Next is prostacyclin analogs, and the example is epoprostenol and iloprost, right? So what they do is that they have a direct vasodilatory action. They are vasodilators and they also inhibit the platelet aggregation. The side effects is that it causes flushing and jaw pain. Finally, we have the drugs that are useful in asthma, and we will study them with this chart, right? It shows basically the type 1 hypersensitivity reaction, in which what happens is that there is exposure to allergen, right, which causes the dimerization of Ig receptors. This is known as sensitization. On subsequent exposure, what will happen, that it will cause degranulation of the mast cells that leads to pro-inflammatory mediators in acute response, which causes bronchoconstriction, and in chronic response it leads to inflammation, wherein there is release of phospholipase A2, which basically forms lipooxygenase or leukotrienes, that causes the mucus secretion, right? We read about the mucus plugs, even the Kirschmann spirals, and eosinophilic recruitment, which was the, so mucus plugs, which were Kirschmann spiral, and eosinophilic recruitment, which was Charcot-Leyden crystals. And these leukotrienes, they act via cysteine leukotriene 1 receptor, right? So this is the pathogenesis of asthma. Let us read about the drugs that will inhibit each of these, that will inhibit one of these steps, right? So first are beta 2 agonist, right? The examples of beta 2 agonist are albuterol, salmeterol and formoterol. Albuterol is what we call commonly as salbutamol. It relaxes the bronchial smooth muscle, right? This is basically SABA and this is a LABA. SABA is short acting beta agonist and LABA is long acting beta agonist. So basically SABA is used for acute exacerbations, right? And the long acting, that is LABA, it is used for prophylaxis. The side effect of these beta 2 agonists is tremor, arrhythmia and palpitation, right? Then next are inhaled corticosteroids, right? Corticosteroids like fluticasone and budesonide. So inhaled corticosteroids, what they do is that they inhibit the phospholipase A2, which prevents the formation of the COX and the LOX pathway further, right? So basically they inhibit the synthesis of all the cytokines and they also inactivate NF-kappa B, which is the transcription factor responsible for the production of TNF alpha. It is the first line therapy in chronic asthma. It is basically given in inhaled form in an inhaler, and the side effect is that it is deposited orally, so it may lead to the formation of oral thrush. This question was also asked. Next are muscarinic antagonists, right? Muscarinic antagonists के examples tiotropium bromide and ipratropium bromide. So you can see they are responsible for decreasing the bronchoconstriction and they can also be used in COPD. Next are anti-leukotrienes. Anti-leukotrienes are montelukast and zafirlukast, right? What they do is that they block the cysteine LT1 receptor. They are especially good for aspirin induced and exercise induced asthma, okay? So aspirin induced asthma and exercise induced asthma में montelukast and zafirlukast are best. Then next is xylitol. What it does is that it inhibits the 5-lipoxygenase and it blocks the conversion of arachidonic acid to leukotrienes. Next are some monoclonal antibodies. So monoclonal antibodies against IgE is omalizumab, right? Then monoclonal antibodies against IL-5 are mepolizumab, reslizumab and benralizumab. Then some other drugs like theophylline. Theophylline question was asked in 22 NEET, right? So what theophylline does is that it causes bronchodilation by inhibiting the phosphodiesterase, right? And it increases the CAMP. Next drug is cromolyn. What it does is that it prevents the mast cell degranulation and prevents the acute asthma symptoms. It is not rare, it is rarely used, right? So these are all the anti-asthma drugs. Here you can see methylxanthines, theophylline, and which inhibit the PDE3 and PDE4 inhibitors like roflumast. They are not used in asthma, they are used only in COPD. So in COPD, roflumast and muscarinic antagonist can also be used, right? So yeah, that was all for RESPI.
Thank you guys for your patient listening. So you've seen for yourself that over 25 or 30 questions from this year NEET are given directly in this and we just can easily solve them. So after that, hope you found this session useful, right? We have covered line to line from the RESPI chapter of first aid. Just remember that in the ocean formed by drops of water, every small effort helps in building for a brighter future. Do leave your suggestions and feedback in the comments, as it will encourage me to make more videos and also post more frequently. Also check out my Insta page for daily PYQs, and as always, like, comment and subscribe. See you for another chapter. Till then, happy learning.